Good evening, everyone. Welcome to Dr. Rajiv Tandon's lecture this evening. I'm very pleased to introduce him. Rajiv Tandon is professor and chair emeritus at the Western Michigan University Homer Stryer School of Medicine. He's an internationally recognized psychiatrist, educator, and researcher. He has authored over 400 scientific publications and given over 1,500 national and international lectures. Very pleased to have you tonight, Dr. Tandon. The floor is yours.
Thank you, Bethany. Good evening, everybody. Uh, I know you're all over the US, so hopefully a range of temperatures stay and you're staying warm. What I'm going to share with you over the next hour uh, is the gap that exists between what we know about schizophrenia and how we practice. And I'll focus primarily on our clinical practice, although I'll touch upon some of the things that we can do better with regards to how we study the condition as well. Before I get going, no financial conflicts of interest. I have worked on DSM-5 and DSM, the text revision, and I am involved in the initial stages of the DSM now currently in development. Uh, but the perspective that I will bring to my discussion today is that I've been a clinician. I've been a practicing clinician for 45 years, and I've been a researcher primarily looking into the neurobiology, the psychopathology of schizophrenia for the past 40 plus years. And I bring to my thinking the perspectives of both the clinician who really seeks solid, definite information, not any hand waving, not any maybe this, maybe that, looks for hard facts that he or she can apply to the care of the next person who walks into their clinic. And as a researcher, I look for data. Uh, Certainly, opinions, impressions, experience, important. Experience, certainly very important. But ultimately, you also want data. Are there data that support the way I think? Now, one of the challenges with data, of course, as we all know, is if I pick and choose the data that I share with you, I can tell you almost any story I want to. I mean, we see that on the news, depending on what channels, what cable channel we turn to. So it's important to look at all available data, uh, but look at data, all available data, really evaluate it, uh, and then provide that the understanding from all these data in a simple, straightforward manner without any hand waving. So, with that, let's get going. What's the essence of what I'm going to share with you? There are 4 points that I really want to emphasize in the course of this presentation. There's certainly a lot more that we need to know about this condition that we call schizophrenia. And so, while there are significant gaps in what we need to know about the condition, there is a lot that we know. Some of I've been working in this field for about 40 plus years, 45 years. And sometimes I think about, we've not made as much progress as I wish we had made in terms of improving outcomes, in terms of understanding, defining this condition more effectively, having diagnostic tests, having curative treatments. But at the same time, I recognize there is a lot that we have learned about this condition. So, the first point that I'm going to seek to make is that while there are gaps, there is a lot that we do know. The second point that I want to emphasize is while there is a fair amount that we know, we're not applying this knowledge to providing the best possible care for persons that we diagnose with schizophrenia today, nor are we conducting the most useful research. But I'll just uh, skip the discussion, maybe mention a couple of things in terms of what we can do better, but I'll focus more on clinical care. And then I'll spend some time listing some key gaps between what we know and what we're doing in actual practice. And finally, touch upon, well, what can we do to improve outcomes by utilizing the knowledge that we have, the understanding that we have about this condition more effectively. And so I'll spend most of my time talking about, so how do we understand schizophrenia today? What do we know? Exactly what do we know? Exactly what does that tell us about this nature of the condition that we call schizophrenia? How that knowledge and understanding can guide optimal treatment. And from a research perspective, how do we answer key relevant questions? And I think one of the big things that I may emphasize, depending on how the time flows, in terms of research, is we need to ask the right questions, uh, and then close on how do we bridge these gaps. And there are things that we can do better in terms of screening, in terms of more targeted comprehensive assessment? How can we provide targeted, individualized, measurement based, state specific care? And all those four terms are important because, based on what we know about schizophrenia today, all those four aspects of required treatment are important. Treatment must be individualized, it must be targeted, it must be measurement based, and it must be state specific. And it's not one treatment does not fit all. And then what's the how can we do the best we can with what we have today? So that's the outline. And so what do we know about schizophrenia? And so this is something which this is from a slide a few years ago. This is what we knew about schizophrenia today. It's not changed much at all, but this is what we would how we would describe schizophrenia. It's a condition with multiple aspects of pathology. Certainly, psychosis, delusions, hallucinations, uh, a big part of the illness, but negative symptoms, lack of motivation, reduced social drive, reduced ability to experience and express emotion, cognitive symptoms, a broad range of cognitive deficits with the condition, generally psychosis beginning in late adolescence, early adulthood, but often preceded by a prodrome, a condition where there were symptoms, but subthreshold symptoms, soft psychotic symptoms, some anxiety, some mood symptoms, some evidence of cognitive decline, uh, and even prior to that, maybe early in life, there were some differences that may have been noted. And once it begins, it tends to be a chronic remitting and relapsing illness with generally incomplete remission. But with all of that, it varies significantly with regards to symptoms, with regard to illness course, with regard to outcome across individuals. And in terms of symptoms, even in the same individual with schizophrenia, the symptoms vary over time. And there is a lot to be desired with regard to improving outcomes in the condition. And and clearly we've known this for the last several years at least, and it's been reflected in the most recent DSM and the ICD manuals that it's a multidimensional illness. It's not just delusions, hallucinations, or positive symptoms, but negative symptoms, disorganization, cognitive deficits, mood symptoms, motor symptoms are important dimensions of the illness. And what's relevant is that each of these six dimensions has different underlying neurobiological substrates, different brain circuitry aberrations that contribute to them, and they respond differently to treatment. So this is something we've known for a while, and we know that essentially this is the way the illness generally progresses. So we've known this for a while. We've also, and so essentially, uh, in terms of etiology, uh, this is something we've known for a few years now. The first gene that conferred risk on schizophrenia was identified about uh, a dozen years ago. But since then, we've identified several hundred genes, several environmental factors are involved. We know that multiple brain regions or multiple circuits are impacted, that antipsychotic treatments are the main treatment, and there are a whole range of psychological social interventions that are useful. So this was what we knew, and but we also know that despite all that we've learned about all the information, all the knowledge that we have about the condition, uh, the advances we've made, we still don't have a specific marker. There's no singular diagnostic test. There is no singular um, pathology that says this is definitely schizophrenia, or if you have this, you have schizophrenia for sure. There's no single factor that is either sufficient or necessary for schizophrenia. And this is despite the fact that we've made incredible advances in terms of the various methods that we use to study this condition. There have been modest improvements in outcome over the 4 decades that I have been in practice, and we have made improvements in treatment, incremental improvements. We don't have a cure yet, but we have made improvements. And the reality of schizophrenia is that we we don't have a very good under. So we've got we know we've identified literally hundreds of genes that increase the risk of schizophrenia. Some that are protective. We've identified a number of a couple dozen uh, environmental risk factors that increase the risk of schizophrenia. And despite the fact that we've delineated, we've defined these many risk factors for schizophrenia, exactly how they increase risk, what they change in terms of the brain circuitry, or in terms of the brain's response to the environment, we don't exactly know. Uh, Although we've identified a number of abnormalities in the brain in persons with schizophrenia, exactly which particular abnormal circuitry causes a particular symptom, for example, we have ideas about, but we don't definitely know. So we have a very poor understanding, incomplete at best, understanding of the etiopathophysicological chain. And this is again despite the fact that we've been studying this for a long time and with really improving technologies. So this is the reality. And this is how how most experts basically think about schizophrenia. We've made progress, but there is so much more to do. And if you look at any paper on schizophrenia, it always ends with we need more data, we need more information. So, one of the things that I and a few of my colleagues decided to do. Actually, the vice chair of CURESZ, Henry Nasrallah, another close colleague of ours, Macheri Keshwan, is also on the board of CURESZ, and I, the three of us, decided that we needed to convene experts around the field and really figure out what do we know about schizophrenia today? Exactly what do we know? There's a lot of information. Literally every year, there are about 50,000 papers on schizophrenia that are published around the world. Actually, 50 to 100,000 if you look at, journals that basically are not indexed at all. So that's the volume of information generated, and all that information, all those papers do not exactly provide uh, they're not exactly consistent with each other. So exactly what do we know? So we convened 50 international experts. Uh, and this has been an ongoing 4-year effort to say, let's actually sit down, let's get together, and figure out exactly what we know about schizophrenia today, what we do with it, how we make progress, how we move on, what's the guidance for clinicians. This has been a 4-year effort, and 2 years ago we got together for 3 days in Detroit, Michigan, to talk about what we know. Exactly what do we know, and what does that tell us about the nature of schizophrenia? And this is and the proceedings were summarized in a publication that we all participated in. Uh, that was published 2 years ago in Schizophrenia Research, and this is exactly what it was called: Facts of Schizophrenia. Exactly what do we know? And what does that tell us about its nature? So this was 2 years ago, and this is what we concluded at that time. Now, this was 2 years ago. It's an extremely heterogeneous condition, both from the standpoint of what its causes, what's wrong in the brain, what its pathology, pathophysiology, how it's expressed clinically, and in terms of treatment response. And there is no single element in any of the above that's either sufficient or necessary. And basically, what it's telling us is this is not one condition. This is not one disease. There are multiple causes, multiple brain abnormalities, and the pathology itself is also its etiology and its clinical expression overlaps with several other entities, with bipolar disorder, for example, with autism, for example, in terms of causes, in terms of brain abnormalities, in terms of clinical expression, in terms of treatment response. So it's not one condition. And from a clinical perspective, it has fuzzy boundaries. And there are multiple psychopathological dimensions, as I mentioned earlier: the positive, negative, cognitive, motor, mood, disorganization. But these dimensions are also shared with other diagnostic categories. And exactly what the core of schizophrenia is, what the essence is, different experts have different ideas. And so these were the dimensions, if you will, that I mentioned. And these dimensions, these aspects of the illness, have a different. This was the conclusion of the consensus of these of all the experts, that they have a different underlying circuitry abnormality, and they respond differently to treatment. From a etiology perspective, causation, and what's wrong in the brain perspective, multiple genes and environmental factors contribute to the risk. And we have some ideas about how they do so, but we don't exactly understand how these risk factors lead to the development of schizophrenia. And while we've identified a whole range of brain abnormalities, neurobiological aberrations, none of these, as far as we've so thus far that we've studied, is unique to this condition. And there is no finding, no cause or no brain abnormality that's unique to the condition that's either necessary or sufficient to define schizophrenia. And from a diagnosis perspective, based on what we know, psychosis should still continue to be the primary basis for identifying it for now, but it appears to be a late appearing phenotype. That is, that whatever is happening in this condition we call schizophrenia, or conditions, range of conditions we call schizophrenia, psychosis appears somewhat later in the course of its development. And psychosis itself, though, is there are multiple ways in which psychosis occurs. And schizophrenia, the pathway of schizophrenia, or the pathways of schizophrenia, just one of them. You can have psychosis in mood disorders. You can have psychosis in conjunction with uh, dementia, for example. And basically, although there are limitations in our diagnostic approach, it's still very useful. And from a treatment perspective, that antipsychotics essentially pharmacologically, they're agents that either block the dopamine, one of the dopamine receptors, the D2 antagonists, and uh, they have weak effects on the receptor. So functionally, they behave like antagonists. They are the principal medications. And these agents, antipsychotics, significantly improve some aspects of the condition, positive symptoms, disorganization. They can help or hurt other aspects of the condition, mood symptoms, motor symptoms, for example, and they have no effects on others aspects like negative symptoms, cognitive symptoms. And relapse prevention is very, very important. Even as we think of acute response, that is important. But then once the person has gotten better, preventing relapses, psychotic relapses, very important, particularly earlier on in the condition where much of the decline occurs. Uh, Clozapine is clearly more effective than other agents, other antipsychotics, in improving symptoms in otherwise treatment refractory patients. And a range of evidence based psychosocial treatments are effective in improving function. So, this was the consensus at that time. So the reality, this was 2 years ago now, uh, it's a syndrome. It's not a singular condition. It's not a singular disease. It's a syndrome, a multidimensional syndrome with multiple causes, if you will. And so at that point, what we concluded in that particular, uh, the consensus amongst us was that, we do have a fair amount of information about this condition. We know a lot. Uh, but are we really accepting what it's telling us about its nature? The reality is, based on what we know, psychoses are heterogeneous. There's wide variation. And these symptom based categories overlap in terms of genetics, environmental risk factors, biology, brain abnormalities, outcomes, etc. And so essentially, what we've tried to do is say, okay, there are different, okay, maybe schizophrenia is not one thing, it's many things. Maybe there are several schizophrenias. Maybe there are 10 schizophrenias, for example. And each schizophrenia has a particular cause, a particular brain abnormality, a particular way it expresses itself, and a particular way, particular treatment that's most effective, particular outcome. And let all that we have to do all that we have to do is basically map these 10 schizophrenias and get these 10 different categories lined up. The fact of the matter is, these categories are not lining up. So we need to accept what the information is telling us and what is it telling us. So with that, so this was the paper that in which all that was defined. So a month ago, we reconvened. So 2 years from that time, a month ago, we reconvened in Boston, and for 3 days, and we said, well, okay, now we need to move ahead. Uh, how do we resolve the complexity of this condition and move forward? And so, actually, interestingly enough, we decided to ask ChatGPT, uh, and so the proceedings were recorded, and we submitted the whole set of recordings over the 3 days to ChatGPT, along with the paper from 2024, which summarized the 2023 meeting. And we said, what's changed? What's new? And this was the essence of what ChatGPT said. In terms of knowledge, there have been no major advances. There's been no major increments in knowledge between 2023 and 2025. And the second thing that ChatGPT said, while the 2023 meeting, as reflected in that 2024 paper, provided a comprehensive evidence based synthesis of what is known about schizophrenia as a heterogeneous syndrome, the 2025 colloquium identified gaps in translating this understanding to improve research and clinical practice and explicitly articulated a trajectory for change. Now, there was one change, one advance, if you will, since 24 to 26. That is, a new medication was approved, which actually is not a D2 antagonist, xanomeline trospium, uh, Cobenfy, as the trade name is, which, at least in short-term studies, appears to have a similar efficacy to existing D2 agents. So, but other than that, no other change. So then ChatGPT was asked, okay, this was ChatGPT continued. So what was the consensus with regard to trajectory of change? Research, stop studying schizophrenia versus non-schizophrenia. This is not one condition. And actually, schizophrenia is not the same at different stages of the condition. You have to deconstruct this construct of schizophrenia. We've got to think about the spectrum of different dimensions, and we've got to think about the different stages of the condition. We need to and then we need to look at relationships between cause and pathology, between a particular pathology and clinical expression, and what happens to it over time at different stages of this condition, in different subgroups based on particular etiological factors, rather than studying all of schizophrenia and trying to explain everything schizophrenia. There is no everything schizophrenia to explain. You have to break it down in terms of its components. And the other thing that the ChatGPT noted in terms of our discussions was that we had a significant discussion on modifiable risk factors. We do know a significant amount about the risk factors in the condition, and there was a significant discussion among the risk factors. From a clinical perspective, uh, you know, ChatGPT noted significant concern expressed by all the experts with regard to not applying the information that we had, the knowledge that we had, to guide our clinical practice effectively. And we really need to think about reform and practice as an ethical imperative, a clinical obligation. And that's what it's interesting that this is what ChatGPT. Now, we were using the most advanced version of ChatGPT, and so I was pretty surprised that it was actually able to pick up these nuances of our discussion. And I could have shared my impressions or that of others, but I think the the ChatGPT summary I present to you only because it's, quote, an unbiased summary, if you will, of what transpired at this particular meeting. And this is something from a stage specific perspective that we need to understand. We do know a lot about the risk factors, genetic risk factors, environmental risk factors. We know about that a lot. We know there are brain abnormalities that develop over the natural development of the brain because of these risk factors that modify aspects of brain development over the first a decade or two of life. And so there's aberrant brain development in response to these. Exactly what is happening, how each risk factor modifies what aspect of brain development, uh, we don't completely understand. Exactly how that particular change, aberration, leads to expression of certain symptoms, we don't completely understand. However, we do know that there are a whole range of risk factors, which in individuals, basically how they interact, we don't completely understand. But in individuals over time, prior to the onset of psychosis, leads to a clinical state in many with an admixture of mood symptoms, some soft cognitive deficits, some aberrations in perception, not really hallucinations, but basically uh, some aberrations in perception, strong beliefs that may not be completely based in reality, but not amounting to delusions. So there are uh, expressions of this significant anxiety, some degree of social withdrawal. So there are clinical expressions, but so we know this happens. We also know that this, in some individuals, progresses to psychosis. In other individuals, it doesn't. Just as you may have risk factors, but you don't develop a high risk state, and certainly don't go on to develop psychosis or receive a diagnosis of schizophrenia, but some do. So high risk state to psychosis, and then once you develop psychosis, it's before it progresses to chronicity, essentially things happen. So there are these changes, if you will, that occur at each of these points of transition. And there are opportunities. We know factors that lead to progression from risk to a high risk state. We know factors that basically uh, modify transition from high risk state to psychosis. We know factors that basically contribute to chronicity or better outcome. And the key is, are we translating this knowledge to our practice, to what we do? And the sad reality is we are not. So this is what ChatGPT, in terms of the discussion amongst the experts over those 3 days, this was what we need to do. These are the changes we need to make. In terms of clinical care, we need to emphasize we need to, relapse prevention. We talk about acute treatment, which is very important, but then we don't pay sufficient attention to preventing relapses. And long acting injectable antipsychotics have an important role in terms of helping us with this objective of relapse prevention. There are other things that we can do, but this is one of the tools that is significantly underutilized, and not just in our country, although the gap is much greater with regards to this in our country than other countries. But it's a gap around the world. We need to be utilizing long-acting injectable antipsychotic agents more effectively, because relapse prevention is important. If you can prevent relapses, particularly earlier on the illness, but certainly all through the course of the illness, outcomes are significantly better. The decline, particularly earlier in the illness, is limited. We need to essentially monitor indicators of relapse. So, in an individual, there are certain signs that suggest that predict impending relapse. Based on what I'm seeing now, uh, in some depression or some other indicator in this person, that it seems as though this person is progressing to a relapse. Address it. Be aware of it. Monitor that. Address it effectively. Another thing that chat in terms of our discussion that ChatGPT noted as a significant need is we need to be using clozapine more effectively, and we probably need to be using it earlier. We Clozapine is very significantly underutilized in our country. It's There is underutilization elsewhere as well, but it's not as marked as it is in our country. Clozapine has a much bigger role to play because it's the only medication that has been proven to be more effective than other agents in otherwise refractory patients. It also has some benefits in advantages in terms of reducing suicidality. And it's if used, it's not a difficult agent to use if people are aware of how to use it. Now, a third thing, we know there are multiple dimensions, pathological dimensions in this condition we call schizophrenia that respond differently to treatment. We need to measure how they're responding. We know that treatment response varies across different individuals. Well, that's a very important reason why we need to measure what's happening to each of these symptom dimensions in the course of treatment. And based on how the person, how these symptom dimensions are responding or not responding, what is getting better, what is not getting better, and how the treatment is being tolerated, we can modify treatment. And so essentially, measurement based care. And we have tools, very simple instruments, very simple scales, not cumbersome, uh, take not more than a couple of minutes to employ. They're very useful in guiding such treatment. Better use of psychosocial treatments. Now, as a separate initiative, some of us experts got together over a year to think about psychosocial interventions. What are the evidence-based psychosocial interventions? What do we do? What do we know about what they offer, what they can do, and how can we most effectively employ them in our clinical practice? How can we know what's available and how to apply them? So this was a paper that was just published last month in the Journal of Clinical Psychiatry. 8 experts got together, uh, including Dr. Nasrallah and Dr. Keshwan, who are both CURESZ board members in this endeavor. Now, the last thing that ChatGPT shared with us was, okay, and in terms of clinical care, these are other things that you guys spoke about and talked about as being important things to address. Treat modifiable risk factors. So we know that cannabis consumption, particularly higher doses of cannabis consumption, it's a risk factor, but even more importantly, it's a very important risk. It basically increases the risk of transition from a high risk state to psychosis. And addressing it, reducing that intake will help in terms of improving outcomes. Emphasize multidisciplinary care. I mean, if you think about substance use disorders, substance abuse as being a significant issue in the context of the care of persons with schizophrenia, the way our treatment systems are structured, you have separate substance use treatment and separate a treatment for mental disorders. And the systems are separate. And it's very difficult for one uh, to access care in both or coordination of care in both. Similarly, we know that medical comorbidities are a significant driver of poor outcomes in schizophrenia, in the context of schizophrenia. We need to better integrate uh, non-psychiatric medical treatment in the care of persons with schizophrenia. We know this in the context of significant variation, heterogeneity. We need a much more comprehensive, individualized assessment and treatment, factoring in which dimensions are more prominent in this person, which dimensions are contributing to impaired function in this person. What are the risk factors unique to this individual? What stage of the illness is this person at? So, because that would be germane to providing optimal treatment, things that we pay less attention to because social determinants are very important in terms not just as risk factors, but also in terms of impacting outcomes. Stress tolerance varies across persons with schizophrenia. That's something that we often don't assess. We need to destigmatize communication. And one of the most important things that was emphasized And it was clear in my mind that it was a major point of emphasis of all participants: avoid therapeutic nihilism. When schizophrenia is a condition with significant variation in outcome and course. Some persons with schizophrenia recover completely. Some have significant deteriorating courses, and there are varying degrees of impairment that you see. But it's really important to recognize that outcomes in schizophrenia can be significantly improved, both in terms of function, in terms of recovery, that I would define as the ability of an individual to lead a meaningful, satisfactory life, productive life from one's own perspective, and use existing treatments more effectively. So this was what I would share with you. This is the tool that I was alluding to, a very simple tool that's actually part of DSM-5. If you were to read it, DSM-5, it's also there in the text revision. Essentially, measuring the six dimensions, 8 items: two for mood, depression, mania; two for positive symptoms, hallucinations, delusions; and one each for the other four dimensions. A simple 0 to 4 scale, which basically anchors for each of these items is provided in DSM-5, guide to how to use it. And it's a very simple instrument to use, fairly reliable with yourself as you begin using it. And in practice settings that I've been part of, I can share with you that it's been very valuable in terms of guiding individualized treatment. So, in conclusion, there is a lot to know about the condition that we call schizophrenia, a lot that we don't know that we need to know. And once we better understand it, we will describe it differently. We may describe different stages of the condition in different ways. We might describe different pathways to a final outcome of chronic schizophrenia versus single episode. So we will come up with a different description, concept of schizophrenia over time. But we know a lot about this condition right now. And we need to do a lot better with what we know and what tools we have. And so, as we think about what we know, this is what we do know, right? That there's a robust body of facts. We know a lot. We know what works. We know what we can do to improve outcomes. And this is a better way to think about it. We've made much progress, but we must apply this understanding in our clinical care and our research for that matter. Thank you, and I'd be happy to take any questions.